All right, everybody. Thank you so much for your potential interest in the NeuroFlow macros that I have developed over the last several years. Um, Again, I've named them NeuroFlow um, by myself, Dr. Daniel Lane, and really the main preface towards this was just a need within our community to have macros done so that we could very comprehensively detail um, that which we check and which we perform on our patients every day in a much more rapid and capable level. Additionally, was also towards the end of providing a very, very detailed and comprehensive note that could be generated and shared amongst colleagues such that any other referrals from out of state, they could know exactly what you had tested, done, and performed, and to what degree. And also for other healthcare providers, particularly our medical colleagues. So I have also paid an independent agency to come in to make sure that we were insurance compliant and to basically go through our notes and to check them for, validity, any shortcomings, anything. And there's 4 doctors in my clinic here. And out of all the doctors, thankfully, I'll be a little narcissistic here, my notes received a 97% grade. So that's from the experts. So anyway, the point is to allow you to be able to wonderfully quantify that which it is that we do in a very detailed, precise, and rapid fashion. Okay, I could go on and on, but let's get to it. So the point of today's video is just basically to really briefly demonstrate some of the potentials of the software and of the macro. Almost all of the permissions have been granted by the various companies that we utilize in our diagnostic lives, and that which are reflected within the notes. Okay, but I just wanted to briefly explain to everybody or show them the potential of the notes. It's important to realize that although it looks overwhelming as we go, okay, obviously the more you use it, the faster it becomes. I can do a full note that doesn't have a bunch of wasted lines, generates typically a 15 to 16 page note, in about 15 to 20 minutes, sometimes less. So it can be a little overwhelming to look at first, and that's only because I'm kind of old school. I'm a guy, I want every option. So you'll see that when you have these different categories, this macro is loaded with options, okay? And it doesn't mean you use them. There'll be 1 or 2 hot buttons that kind of have everything that you need. Once you learn how to use those, you'll be off to the races. But if you want other options there, then they exist. There's also typically a normative values button with most of the macros. Then there's a brief version and a detailed version. So on most things, all 3 will be there. Not on everything, but on most of the things that we use most often. So for instance, the category of frontal cortex has a frontal cortex normal macro button. Then there'll be frontal cortex brief. You might not want to go into all the detail. And then there'll be frontal cortex, comprehensive and full. So you'll see that within the body of it as well. Okay, so to start, I always have my staff, they collect the paperwork that we have given to our patients. Now I have 2 clinics. One is my chiropractic clinic, which I do some neurology out of. Well, actually quite a bit of neurology out of. And then my actual neurology clinic, Mid-Atlantic Brain and Neurological Rehabilitation, MABNER. I will be including both sets of paperwork with the macro. And basically one is more comprehensive for neuro, one is more all-in-one. And you're free to use it, change the logo, that's totally fine. And then what happens is there's a macro for the front desk, which is at the Mid-Atlantic Brain Clinic. There's a macro in the front desk, which I will include if that version is what people want. And that's here. And that's the Mabner front desk. Okay. Otherwise, my front desk at my Chiro clinic just uses my NeuroFlow by Dr. Lane, the most current version. Okay. And then they go into subjective and they complete the initial based on what the patient has provided. So the patient comes in, you hit the initial button, and there it is. Our staff runs through this: occupational history, family history, health history, blah, 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 blah. Anything with the red is more inside of there. So they'll fill out the occupational history, they'll click on family history, do that, or is it essentially normal? Come back, fill out the health history, medications, so on and so forth. Then they get to the review of systems, okay? And here is our usual review of systems. Now you notice if you go back, here's review of systems again, okay? And then close at the end. And here's the Mabner front desk, which is a little bit different, okay? But again, you'll have the paperwork for both. You don't have to use this if you don't want that, but it's there. I also have motor vehicle crash reports. There is one for my clinic here, which is less comprehensive, and one for the Mid-Atlantic, which is more comprehensive. And I can include that as well, okay? So that should be, I need to add that too in there, okay? Now, and again, your review of systems is there. So my staff does that. You can do that if you want to. I go in, I hit copy. Okay, chiropractic assistant, check the notes. There it is. The patient has been asked to, this is a fake patient by the way, the patient has been asked to provide a history. Okay, so I go in and I copy all of this that my staff has data entered, and that right there is the patient history. From there is the rest that I just outlined: occupational history, family history, blah, 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 social history, then the review of systems. All of this has already been done for me, but it's done by my staff, but all of it is right there for you. And then the concluding line, which is very important: the history and consult was concluded, permission was obtained to examine the patient. So we hit the Control C button to copy that, hit cancel, go into my note, okay? Now, that was all under here, or sorry, under the initial. That was all that. Now we continue to the chief complaints. This is my part. Here's the symptom list: chief complaint 1, chief complaint 2, and chief complaint neuro. If there happens to be a tertiary complaint, here it is. By the way, most of the menus within this run from left to right, top to bottom, along the lines. Some of them go up and down, okay, but most of them run this way. I had changed that. Originally everything went up and down, but it's a little more user-friendly going across. So here's your symptom list. Here's your chief complaint 1, chief complaint 2, chief complaint neuro, and I'll show you those in a second. Here's a tertiary if you need, previous chiro care, past interventions. Here's the motor vehicle crash report, which is also on the front desk, so it's in 2 places. Now here's maybe just your title for your chief complaint title. Okay, I do that all over the place, just the intro and title. Okay, see, like that. Then you've got chief complaint itself. Here's a verbal history intro that I used. That's when I sat down and talked with the patient. That's what I found. Here's the history done by the patient. Okay, and then here's a VAS scale if you want one, and here's a very powerful button that I like to use at the end. The patient denies any other radiculopathy or paresthesia, dysesthesia, and further denies any neurological or pathological symptoms. Really important to have that in there from a legal perspective. So it's all included. Okay, so let's start off. Symptom list. So this patient has headaches. Okay, so you see there's everything you can imagine in here and then some. I'm always adding to this stuff, and these things I typically, the whole program I change and add to it every day or two. So when you get a quarterly update, there's going to be a lot of stuff in there. Okay, headaches, there's some myalgia, we have some visual disturbances. Let's just say there's fogginess, sense of floating, decreased memory, some motion sickness, dizziness, and way up back at the top, neck and cervical spine pain. Okay, so there's your chief complaint symptom list. Okay, now we come in and we say the history was provided by the patient. Now remember, I've copied from the other thing and I just paste like that. So now we look up and we have, here's the main symptoms, here's the history by the patient. Okay, goes in and then transitions straight to the occupational family history and everything else, the review of systems, and the closing note. And the subjective is done, quick as that. Okay, let's say that we wanted to go in and I wanted to describe the chief complaint a little bit more. Okay, so after this section right here, I could go in and let's talk about chief complaint number 1, and then I'll run you through it. So it's on today's date. Where's the discomfort? Say headaches, neck. Okay. And then if it was neuro, you could do the neuro one. The discomfort out of 10 is a 4 or a 5. Frequency 50%. How bad at its worst? 9. Best 2. Okay. Frequency of episodes a day per week, let's say variable intensity but daily. Okay, and it was secondary to a trauma that occurred 2 weeks ago. Since then it has been worse. Okay, now we'll go in and state what that trauma was in a minute. What aggravates the discomfort? Most movements, and you can go down here, there's a lot of different things. Okay, most movements and light. Okay, I can add that. Well, it relieves the discomfort. Nothing that the patient can attest to. Okay, the quality of discomfort is dull, aching. Does the pain radiate? Here we have all sorts of options. There's radiates, does not radiate. There's every dermatome level on the left, on the right, bilaterally. Okay, there's every peripheral nerve distribution I could think of on the left, on the right, bilaterally. There's common nerve entrapments. Then there's just areas of the head, the face, all right, the gluteals, and that kind of situation. So it's all right there. In this case, we'll say there is no radiation, so the symptoms do not radiate. Okay, or you could just say radiates in a dermatomal, radiates in non-dermatomal, or be specific. Okay, and describe the radiational symptoms. Here's all of the different descriptions. We'll say, well, there's normative in function in this regard. So now let's read our thing. Mr. North presents to the office, chief complaint of cervical complexes, headaches, upper thoracic, paraspinal discomfort, pain. Rates the condition 5 out of 10 on the VAS. Notes an approximate frequency of 50% of the time. The condition is worst is rated 9, best is a 2. The condition is variable in intensity but daily. The onset of the condition symptom was secondary to trauma and was first noticed 2 weeks ago. And here you can't really have a button because it's so variable. After and a motor vehicle crash, and you might say see motor vehicle crash report. Okay, since the complaint began, symptoms have generally been worse. Reports the pain symptoms by most movements and light. States the condition is relieved by nothing that they can test to. The quality is dull and aching. Notes that the symptoms do not radiate and quantified as normative function in this regard. Patient denies any other radiculopathy or paresthesias, etc. So there you have a very detailed report on the subjective. Okay, so now we move to the objective. Okay, and here you have your new patient exam and neurology. That's pretty much all you need. Okay, new patient exam is normal musculoskeletal, and here's neurology. I have the fast buttons over here that I use all the time. Okay, now once again, I usually have my vitals taken by my staff, So they're already there and waiting for me, but in this case, since the patient doesn't really exist, they're not done, so I'll add them in. Okay, so if we go into new patient exam, because that is a new patient, and go along here, okay, then we'll come back to neurology later. So the presentation, start with that. Alert, oriented, pleasant, cooperative, well-dressed, well-groomed. Let's say that they're concerned, sure, and in obvious discomfort with photophobia. Okay. Then we add the vitals. Height, let's say they're 5 feet. Inches, 10 inches. Okay. Weight, 210. Pulse, let's say it's 95. Oh, 65. Whoops. Okay. I don't usually enter this, so. Okay, left and right, 02 sets. Don't really need that, but anyway. 125 over 85. 135 over 75. Ooh, dysautonomia. Okay, so there's your vital signs done. Okay, height, weight, pulse, temp, everything finished. Okay, then we move on up here. There's your vitals. Now we move on to the complete physical. Okay, so I like to use this right here. Complete physical, the patient's age. Go back up here, 40. Okay, hit that. Patient's age is 40 years old. And now your complete physical is done. Now, the physical has different versions. Here's the complete physical. Okay, there's more of them here. So the complete physical with no auscultation and brief. Okay. Then if you check here, complete physical with all systems. So on this one, okay, here's neck, heart, extremities. The heart doesn't have auscultation, just visual inspection, and there's no abdominal. Okay, and then it's very just basic neurological here. So that's the brief. It says right there, no auscultation, neuro brief. Okay, so that's, if you want the full physical, that's that button right there. Okay, then we just hit this daily visit intro detailed, which describes what we're going to do today. Okay, and then we go into it. So here's your observation, posture, and we just follow along up to extremity. Observation. Okay, hit the title. Was there scarring? No scarring. Masses? No masses. Any atrophy? Let's say there's none in this case. Leg length? Sure. Leg length, let's say short on the left. How many centimeters? 1.5. Okay, for those of you that like leg length checks. Then we move on. Posture. Do you want any postures? Here's the intro. Here's your various postures. We'll say there's a head tilt to the left. Okay, and high right pelvis and thoracic hyperkyphosis. Sure. All right, here you got pitch. All sorts of different things. Shuffling gait, all sorts of things. Okay, so there's your posture. Then we move down to here, palpation. Lots in palpation. So here's your intro for palpation. Now we go into tenderness. Where were they tender? And again, if you're neuro, you don't necessarily have to have all this. I'm just showing it to you. Okay? So there's your areas of tenderness. Then we go into actual palpation here. This is tenderness to palpation. This is palpation. Muscle tone. What type of muscle tone did you have? Pick it. So right now, let's say hypertonicity and splinting. Okay, of what? Of the. Here's different options for different menus you'll figure out later. Mostly right now is of the. Then the muscle list, which I've made, which has hundreds of muscles, left, right, and sometimes bilateral. Okay, so where did you find it? I have almost every muscle listed here you can imagine. It starts off with lower extremity, okay, then transitions to upper trunk and extremity, and then at the end down towards the spinal. Okay, so coming way down here. All right, so here's just paraspinal. So let's say it was, well, they got headaches, so we'll say there's a bilateral suboccipital, bilateral cervical complexus. Okay, and that's for the hypertonicity. Maybe we had another one. Okay, so maybe there was spasm or hypotonicity. Okay, of the let's say the right glute. Okay, so maximus, medius, which one? We'll say right piriformis and right maximus. Okay, there's your palpation. Okay, go back to the main menu. Is there edema? Click it. Is there trigger points? Click it. Okay, palpation's done. Range of motion. So here's our introduction. Here's a range of motion intro, which is full. Don't usually need that, but you have it if you want it. Here's a range of motion intro, which is brief. See, here's the full one. Explains about range of motion. Okay, probably don't need that. Here's the range of motion brief. I like just that. Okay, here's cervical, thoracic, lumbar. Cervical full, thoracic full, lumbar full. SI joint. Here's inclinometers if you use it. Here's chest expansion if you use it for range of motion. Okay, here's Mopal stuff. Here's Medicare. Come down here, and this is segmental range of motion. So let's say on the actual range of motion, cervical was full. Okay, and we're just dealing with headaches, so that's good enough. Okay, but you could say thoracic's full, and lumbar you could go into if you want and say, okay, how much is it? So let's say 65 on flexion, and then with pain, without pain, ask you various options with pain. Extension, say 30, and it's nothing, no pain. Left lateral 20, okay, it's nothing. Right lateral 20, it's nothing. Left rotation 25, and nothing. And say right rotation 15, and we can say recreating radiating pain. Okay, so there's your range of motion. Now you have segmental range of motion. Okay, click that and get your body list. Where did you feel it? And say like that. And that's your sublux or segmental dysfunction areas. Okay. Now we go back. That was range of motion. Orthopedic. Okay. Start here. Here's your intro if you want. That's more detailed. All right. Cervical, thoracic, lumbar. These get very detailed. Okay. My favorite is under here. All right. You'll learn that quickly. And go into there. Ortho test list by region, okay, because this is basically just spine. Go here, and it's everything, okay. So here's the intro, here's the brief intro. I like just the title, so that's the brief intro, okay. Here's the cervical, thoracic, lumbar, okay, nerve root, vascular, shoulder, knee, you name it, okay. So let's say cervical ortho test, what was positive? Let's say that Soto Hall and maximum compression on the right or positive. Negative, maximum compression on the left. Valsalva was left, vascular insufficiency was negative. Okay, ortho's done. And we go back here, motor sensory reflexes. This gets very robust. This one goes down, one of the rare ones that go down just for readability. And so here, you start off, we have pathological reflexes. These red ones have much more behind them. So pathological reflexes, here's a short version of this stuff. Here's them just normal. Here's all reflex, here's just DTRs or MSRs normal. Here's all reflexes normal. That's DTRs and pathological. Okay, if you want more control over this, go in and look what you've got here. Pathological reflexes general, just Hoffman's, just Babinski's. Patho reflexes normal, okay, all normal. So you see you've got options there. Same thing with your MSRs. Here's upper extremity, lower extremity. Here's them normal. Okay, here's many more options. Okay, and you just see which ones you like and what you get used to. Okay, oops. Then sensory testing. Sensory upper, sensory lower, sensory normal. Okay, and again, tons more options for sensory. depending on what you like. Same thing with muscle testing. Okay, here, I love this button. This is just going to list the individual muscles full, all of them. Here's muscle testing, normal upper, normal lower. If you delve in here, here's normal upper and lower. Okay, here's variable strength muscles. So some of them on there, you might say, okay, you pick a bunch of them, and then it'll tell you, you know, these are 4 out of 5, and then you come back, pick more, and it'll say these are 3 out of 5. Okay, that's a really powerful button. So is that one. Okay, back to this. Now here's more sensory motor testing, and then pediatric reflexes. Pediatric reflexes are here. Okay, more sensory motor testing. Here we got graphesthesia, basic and advanced. Stereognostic, basic. Okay, percussion myotonia, barognosis, basic. MSRs, dual extinction, pendular reflexes. Okay, so even more things that follow Dr. Carrick's teachings. Okay, so we'll go back, be quick about this. Let's just say that all the reflexes are normal, nice and quick. Okay, so you click that. Deep tendon reflexes, MSRs, and pathological reflexes are all normal. Okay. Now here you've got, you don't need to go in there because we just stated it there, but there's options for you. Sensory. Well, sensory in the upper extremity, sensory lower extremity, sensory normal. We'll say sensory normal in this case. Which modalities did you check? Pinwheel, vibration, soft touch. Okay. And what did we check? Upper and lower. And it's going to default and say also V1, V2, V3, because I checked that on everybody. And you'll see sensory examination basically shows normal findings with those sensory modalities, upper, lower, as well as the trigeminal distribution. If you go more into here, you can include or not include the trigeminal distribution. It's up to you. There's the options. Okay. Go into muscle testing, and we'll say that in this case the right piriformis, right glute max, those were weak at a 4 out of 5. Okay, and that's it. Now, if you want more muscles, you can go in there to that button again, or go into muscle testing, hit this one, and it'll allow you to add multiple muscles, multiple levels. Okay, so there is the musculoskeletal. Finally is extremity. Extremity here is CCEP, which I've been trained in, if any of you are. Here's palpation, here's rib fixations. But generally speaking, on this page, just start here, work your way across. You only really need these 3 if you want, but they're all there if you want to get into it. So we would say extremity intro right there. I hit joint dysfunction. Where was it? Of the, what joint? Well, let's say it was the right and left scapulothoracic and the right gluteals. And again, you can see everything's, lots of stuff in here. Okay, all extremity stuff. Okay, then what are the findings? Findings: decreased range of motion, maybe some tenderness to palpation, achiness, stiffness, tightness, pain, discomfort, decreased strength on motor testing. Okay, and this goes on and on and on and on too. Okay, and there you have it. Okay, there's your extremity. So, done. Musculoskeletal is done. Woo. Now again, this is taking a lot longer because I'm explaining as we go. Now we go back to the main, and let's, for those of us more interested in neurology, obviously, here's the juice. So neurology, we've got the neuro intro, and then you just move across, and almost everything outlines that which Dr. Carrick has taught us, okay, or trained by him. So we go in, neuro intro. Here you've got the different types of neuro intros. Here's a brief intro, here's a neuro exam intro, re-exam intro, and the daily visit intro. All right, now here's a standardized one, which is short. Here's standardized, which is long, okay. Then you can do the neuro intro by test. So here's the affect, the facial symmetry, strabismus, eyelids, blink rate, hypomemia, corneal reflection. So if you don't like the default, okay, you can, here's all the stuff, all right, that is itemized in there, okay. So let's go back in, and we'll say, I like this one, neuro intro standardized short within normal limits. I'll ask you what day is the exam. It's today. And now you see, okay, detailed neurological examination of this day. Here's what I noticed. Okay, I like to put that in there, and then if there's usually only one or two things that are off on the patient, I'll just go in there and, you know, there is no evidence of facial motor paralysis. There is no pathological orbital. There is a right-sided pathological orbital reaction. Noted. Done. Then I'll usually highlight that and italicize it so I know later what I'm looking at. Okay? But if you want the individual ones, they're all in here by test. Okay? Here's a neuropsychological one expanded. Okay, and there's many options in here for everybody. But you really only need these two in the re-exams. Okay? So let's go back. There's the intro. And you see the intro is very comprehensive. Now we can go into the physical evaluation. Okay? And I don't use this too much because it's above there, but if you wanted, you can find it here. Okay? Then vital signs, we already have them, but if you didn't, you could add them here again. Okay? Then gait and postural exam. All right, here's the title, here's the exam normal. Then you can really get into different phases of gait if you want. Okay? So let's just say that the gait and postural exam was normal. Okay? Good. Now, cranial nerve exam. This gets very detailed. We've only commented on it way at the top up here, okay? But now you can come down with detail if you want. Cranial nerve exam. Here's the intro. Here's it normal. All right, so if you want, you come down and, oops, you come down and hit there. Detailed exam was normal bilaterally. Or, okay, you can go individually to each of the cranial nerves, and there's many options within that. Okay, and it'll go through it with detail with you. Okay, so maybe you only looked at 3. If you've only looked at 3, you shouldn't say that all are normal. Okay, that's not even ethical. Okay, if you look at all of them, then you state that. So they're all individual there for you. So let's just say in this case, they're all normal, and then maybe there's just one that's off, so you might go in, save for decreased pupillary constriction to light on the left. All right, so maybe in that case, there's only one thing, so why go through all the work of that? Okay, it's there. There's your cranial nerves. Now we get into the frontal cortex. Okay, here's your intros down here. Here's your frontal cortex normal and other normals. Okay, here's the frontal cortex comprehensive that's going to ask you all of these things. Okay, one by one. All right, so then if you just want to test one by one, like maybe you only did 2 or 3 of them. So here they are, you can pick them. All right, so we have facial expression, finger tapping, open closed fist testing using UPDRS scales, Meyerson sign, hypomemia, arm swing. Then you see here you're going to see arm swing UPDRS, arm swing basic, dual tasking UPDRS, dual tasking basic. Okay, finger tapping UPDRS, basic, open close, basic, because the UPDRS is pretty detailed and it's going to ask you the numbers. Okay, and what phase and what did you see? It's very comprehensive. The open closed fist, or sorry, whereas the basic one is just going to ask you. So let's just show you here. Let's say here's the frontal cortex, and we'll say Meyerson sign. Okay, was present. Okay, then let's go into finger tapping basic to show you. Which side was decreased? On the left. Okay, patient decreased on the left. Let's try open closed fist to show you the UPDRS. Oh yeah, on the right, grade what? 2. Was it decreased? It was decreased. Let's say during the middle third. How many hesitations on the right? 1 to 2. How many freezes? No freezes. Okay. Left, let's say it's a 1. Okay. It's decreased. Which phase? Let's say during the beginning third. No hesitations. How many freezes? None. Because that would be a higher grade, right? So here, open closed fist. Grade 2 on the right, decreased amplitude during the middle third. 1 to 2 hesitations and no freezes. Grade 1 on the left, decreased amplitude during the beginning third. 0 hesitations, no freezes. So there's your UPDRS done in an instant. Okay? And you can go through with all of those tests. And if you have findings, again, I like to go and do this and that. Okay? Now, cerebellum, once again, intro, normals with no statement. So, to show you the difference, here's just the intro, okay? Here's normals brief, and it'll state, cerebellar examination was essentially normal and appropriate. Now, sometimes that gets annoying because I need to get that out of there because I'll say 1 or 2 of these things was positive. So if that's the case, you just don't want that, it'll say this one, which just says straight into the testing, okay? So that's the normal. Sometimes they're all normal except one thing, so you could just go into here and then just change that one thing. Otherwise, okay, we start off and well, here's our intro, okay, and then what did you do? Well, here's Romberg's, they swayed to the left, okay? Finger to nose testing, what did you notice? Dysmetria, overshoot, parietal drift, okay, so let's say dysmetria and a terminal tremor, and that was on the left, okay? That's finger to nose testing. Rapid alternating movements, all sorts here. Flexion extension of the fingers, the arm straight, okay, glenohumeral, arms bent at the elbow, here's the wrist, finger, nose, fingers, okay, so it's all in there. So let's say that was decreased on the left, and this one was decreased on the left, and that one was normal, or say appropriate, bilaterally. Okay, rapid alternating movements of the upper extremity, forearm, elbows with pronation, supination was appropriate bilaterally. The rest were all decreased. Okay, everything on the left. So, back to the cerebellum. Now finger, nose, finger testing. You get the point. Here's heel to shin testing, patellar leg tap testing, localization, tandem gait, tandem stance down here, Fukuda's, dysdiadochokinesia, the actual term, which I try to avoid unless it's true, dysdiadochokinesia, in case medical professionals are reading that. It's like Romberg's, you know, we're saying it's a sway to the left, it's not tertiary syphilis. Okay, here is Luria's 3-step test. Okay, that's in there, tandem stance, retropulsion pullback test, okay, and the accuracy test, the rebound test. Lots of cerebellar tests. Okay, cerebellar exercises. This button I almost never use. It's there for you if you want. Okay, I didn't develop a lot of this. Some of this stuff I just found on the internet, and I haven't. It's infinite. The exercises and the things that we do. That's the only section of this that isn't in there, is because what you do is so highly variable. How do you make macros for them? So there's some basic things in here if you want them. They're just there. I never use it. Okay. So there's cerebellum. Oculomotor, this one is very detailed because it's mostly what we do, right? Thank you. Dr. Carrick is wonderful stuff here. Okay, so what do? Here's gaze fixation. Well, so let's do the intro first. So here's visual inspection if you want. Okay, ocular motor normal. You see it's red, there's more things. You got ocular motor normal brief summation. Okay, which basically just says, you know, hey, all ocular tests are normal. Smooth pursuit, saccades, convergence, divergence, optokinetic induced nystagmus, gaze fixation, via-aware presence, and cancellation, all appropriate. Okay? And then you've got this one here with no statement. That basically just goes into the test being normal. So, let's run through that a little bit. Ocular motor, here's the intro. Okay? Gaze fixation. Was able to fixate gaze. Did you see anything? Normalcy with no unwanted movements, but they could have saccadic intrusion, square wave jerks, etc. Okay, gaze holding. We've got gaze holding and gaze holding or normal. Okay, so we'll say Well, let's show you one. Okay, so gaze holding was not able to hold gaze where? Up and to the left. Okay, for 15 seconds up and to the left. Then there's end gaze holding if you want it. Smooth pursuits. Under smooth pursuits, lots of options. Here's horizontal, here's vertical, here's oblique, one direction, oblique the other direction. Here's smooth pursuits normal, here's smooth pursuits in general. Okay? Get as detailed as you want with all these. I like the general one because it's quick. Which plane were tested to be found as off? So let's say the horizontal was off. Okay? Were they appropriate? Not appropriate. Okay? In which direction? Let's say bilaterally. And here you can quantify it. Worse to the right. Okay? What findings? Let's say there were saccadic intrusions and backup saccades. Okay? And a little bit of off-axis deviation. And you see there's lots of findings here. Okay? And at what speed? At 1, 2, and 3 hertz. There you have it. Smooth pursuits in the horizontal plane were tested and not appropriate. If you go back and you don't like something, just click on the button, it takes you right back to the menu. Not appropriate bilaterally, worse to the right. Findings include saccadic intrusions, backup saccades, and off-axis deviation. Breakdown as per above occurred at 1, 2, and 3 hertz. All other planes of smooth pursuit testing were appropriate. Maybe they weren't. You want that out of there? Just take it out. But it's there for you as a default. Okay? That's smooth pursuits. Saccades. Very tricky with saccades, okay, to develop this. Here's your saccades normal. Here's your saccades general. Here's if you want to get detailed. Horizontal saccades get very detailed. Reflexive and volitional, okay? Here's your oblique saccades, okay? Again, reflexive, volitional. You get the point. Anti-saccades, okay? Horizontal, vertical. Here's horizontal saccades general, obliques general, anti-saccades general. Here's horizontal, vertical, okay, it's the same thing. Oblique, here's anti-saccades, here's express saccades, here's memorized saccades. So everyone I can think of, they're all in there. Okay, I like the general one, as I told you. So let's just say general, though, is not going to talk about express or memorized. You'd have to go in and change that. So this is which direction were the saccades tested, horizontal and vertical. Okay, were they not appropriate? Where, let's say, on both up gaze and down gaze. Okay. What findings? So let's say we had hypometria, two-step saccades, okay? We had increased latency, dysmetria, decreased velocity. Okay? Sidedness of the findings, to the right. And there's obliques, there's everything in there. Saccades tested in the horizontal plane and vertical plane were not appropriate on both up gaze and down gaze. Findings included hypometria, two-step gaze, increased latency. All of the planes of saccadic testing were appropriate. Okay, if they were, great. If they weren't, take it out. Just like that. Okay, saccades is done and wonderfully quantified. Okay, and again, you can get very detailed with this. I'm just flying through it. Okay. So we're under ocular motor. Okay, saccades. Convergence, divergence. All right. Was a convergence insufficiency noted? Was not noted on convergence or divergence. Was there an accommodation spasm noted? It was noted on the left with convergence in both pursuit and saccadic movements. Okay, there's your convergence, divergence. Optokinetics, you get the point. Here's normal. Here's the main one. That has everything. Here's a brief one. Okay, here's a very, very, very detailed one. Okay. So let's just say that the OPK brief, let's just say, was inappropriate to the left. Okay, the nystagmus was not appropriate. And what did we see? All sorts of options here again. Appropriate amplitude, frequency, and gain. All right, decreased amplitude, frequency, and gain. You can talk about the slow phase, the fast phase, to the left, to the right. What did you see? Lateralization, nystagmus. Okay, that's all in there. So I'm going to say decreased amplitude and frequency. Okay, Optokinetic induced nystagmus to the left. Findings included decreased amplitude and frequency. All other planes of nystagmus were of acceptable values. See, done. Okay. So those brief buttons are good if you have if you have some normals. If you have no normals in any direction, don't use the brief buttons. Okay. So there's your optokinetics. VOR testing. Okay, that gets detailed. Okay, so you see we've got yaw. Now this is just for the presence of the VOR. Horizontal, vertical, cycloversional. Here's them combined. Here's a Helmagi with RELPs and LARPs, or a HIT. Okay, hit impulse testing with RELPs and LARPs. Here's VOR cancellation. Here's VOR cancellation detailed. Here's eye head following, essentially same. Here's Helmagi normal. Okay, here's a HIT peripheral and central, the difference between the two. HIT simple. Here's subjective visual vertical. I have developed this. I have my staff enter it. Okay, we'll get into that in a second. Here's per-rotational nystagmus. Here's post-rotational nystagmus. Here's head shake nystagmus. Okay, here's dynamic visual acuity, and then more tests. So here we have rotational testing, where you rotate the patient, Dr. Carrick taught us, and stop and ask them, do they still feel like they're moving in the same direction or the opposite direction, as a nice little bedside test for velocity storage. That's in there. Medial malleolar test for a superior canal dehiscence. That's in there. Okay, head heave test, subjective visual vertical, head heave normal, red desaturation test, and here's more gaze holding. Okay. And then Maddox rod testing. Maddox rod testing, the intro, normal, and then you can get detailed into the Maddox rod testing. I might have to do a little bit more of that because I've got it testing on both sides, which you don't have to do. But that'll be included in an update. Excuse me. Okay. So that's your VOR testing if you want it. Then you've got Helmagi just over here. Accommodation. Do they have a hyperopia? Here's just basics with yaw, pitch, and roll. Here's a detailed for the VOR cancellation. Then other tests. Here you've got your tropias. Okay. You got your cover and cover phorias. Your corneal reflex test, Hirschberg corneal reflex test. Okay. Subjective visual vertical again. Accommodation, strabismus, hyperopia, per-rotational, post-rotational. Okay. Head shake nystagmus, dynamic visual acuity, eye head following, yaw pitch roll, calorics if you want them. Other test normals are in here. Okay, so here's all these things that you did. You know, it's annoying if you have to go through stuff and put in data when it's just normal. So all those back there are listed here as normals. Okay, and then even more tests here. All right, so I'm not going to go through and enter all of those. You see the detail that's in there. Every test you could possibly think of, I think, is in there. Okay, so that's your VOR testing. This is all under ocular motor. Okay. Now you'll see a lot of spillover. Here's vestibular. So we go into the vestibular section. Now here's just the intro. Here's the exam normal. Love that button. What does it say? The lazy version. The patient did not present with aberrant ocular motion such as nystagmus. You're able to maintain gaze centrally in all directions. The VOR was present in all three planes, and the gain was appropriate with HIT testing and SVV and or with bedside challenges. Patient was able to cancel VOR. No evidence of ocular skew or pathological tilt was noted. Post-head shake nystagmus test was negative. Canal challenges were appropriate, negative for canal lithiasis. That kind of covers everything. Let's say you didn't check the canals. Just go like that. Done. Okay? But maybe you want to get into all the testing. All of that. So, as we know, you just hit the title. Okay? Go into the testing. And here, again, it's all the things we've already showed you that are under ocular motor, but here they're under their own section. Okay? Other tests, and then gaze holding, and tests as normals. Okay? So, let's do per-rotational nystagmus. Yeah, that one gets complicated. Let's do the corneal reflex, upward. Okay, which eye on the left? Okay, type of ocular deviation, downward. Okay, right eye, normal. Okay, on the right. no ocular deviation. Okay, so that'll tell you the Hirschberg test. Then let's do other test normals. I had following was normal. Go back here and let's do rotational testing. To the left, continued rotation in the same direction. Okay, and left. All right. Appropriate feel. Oops, I should have said right. Appropriate feeling and sensation. Okay, so here's the rotational testing. Rotational testing, velocity storage of the patient with eyes closed to the left revealed continued rotation in the same direction. Rotational testing to the right revealed appropriate feeling of cessation of rotation. Perseveration of the feeling of rotation after cessation of the actual motion has a probability of increase in gain of velocity storage if in the same direction, and a decrease of velocity storage if it's a reversal of the feeling of rotation is experienced. Expected/normal function would be for the patient not to feel any sense of rotation upon cessation of the stimulus. Okay, so it talks about the velocity storage, not the VOR. Okay, just as a little example. So there's your vestibular examination, and again you can highlight that. Thank God, we're almost done. And again, this is much longer than it normally takes, but I'm just showing you all the options. And it depends how much you actually test, but I think you get the point that almost every test I can possibly think of is included in this. Now we go into neurology other tests. Okay, now skip that for a second. Let's look over here. Motor sensory reflexes. That is the original musculoskeletal that we first went through. So if you just go to neuro and just enter neurology, then you can still get back into it here with what we talked about, because maybe you don't do all that other stuff. But here you just did the reflexes or the graphesthesia or whatever, you know. So it's there for you here. Neurology eyes, okay. This is just, you know, some basic things if you don't want to get into the detail of all the other aspects. Okay, what do you notice just looking at eyes? I never use this button, but it's there. Now, here's if you spend a long time with the patient, it's done for you. It'll ask you how long you spent with them. Here's what button I love at the end of it, neurological and clinical impression, just the title. Then you type in what it is. Normal values, here's pre-treatment intro, post-treatment intro, chest expansion if you need it, and a daily neuro visit, okay, with all of these type quick things. Okay, this daily neuro visit, I don't believe was mine. It was one of the macros that was included. So I don't use that. I leave it in case you want it. I don't use these three either, but they're there in case you want them. Okay, and I don't use that one. Now, neurology, other tests. Here's where you find all the tests that we typically do as per Dr. Carrick's instructions. Here's your fundoscopic examination. Okay, so what did we see? We see left square wave jerks and a right beating nystagmus. Oh, that person's screwed. Okay, bilaterally. So, fundoscopic examination reveals that. Okay, Tinetti testing. The Tinetti testing will guide you through. What was the gait score? Let's say it's 12. It was perfect. What was the balance? 12. Okay. So the overall is a 24. So they're a fall risk. Okay. There's your Tinetti testing. Tells you what they've got. Here's your NSI testing. Okay. NSI testing just tells you, hey, what is NSI? Here's where you go on the internet. And if you want to put in findings on NSI, you do that yourself, but this just says the testing was done and what it is. Okay, subjective visual vertical. Okay, right eye. Head neutral, how many degrees? Let's say 2. Head neutral or head flex to the right, 3. Left, 0. Now we're on left eye. 2, 0, 0. Okay, both eyes. 2, 3, 0. Okay, now you see your subjective visual vertical, and I've got a device that I made that does that. I love it. Thank you, Dr. Traster. And I can teach you guys how to make it if you want. It's great. It's wonderful, and it's super cheap and affordable. The hardest thing was calibrating the piece of paper which you're going to laminate. Okay, so there's your subjective visual vertical, right eye, left eye, both eyes simultaneously. Okay. Now, CAPS, posturography. Again, click it. It's just going to tell you what the CAPS is, where to go on the internet, and that it was performed. If you want CAPS findings, you'll see down here, okay, diagnostic testing findings. Then I'll get into that in a second, okay. Here's saccadimetry. Click that. Tells you what saccadimetry is. Thank you, Dr. Ober. Okay, and that thing. Occasionally you see this happen. I have no control over this. This is ChiroTouch, and you just have to go in, grab it, and hit the print you want. It defaults to times for me anyway. It just does that. We can't get them to fix that. Okay, it's rare, but you know, just a quick review and you'll see it. So there's the saccadimetry, explains it, where to find it, that it was done. VNG, VOG, same thing. Okay, here's the VOG. Here's CBS, brain testing. You have two different versions of the introduction. Depends which one you like better. Okay. And that talks about CBS testing. Okay. Here's the other one for neurocog. All right, they're both a little different. Here's a tilt table intro if you do tilt table testing. Okay. And what you did on there. So which is when did you do the tilt table testing, and look below or see the chart for findings. Okay, here's canal testing repositioning. So this is going to lead you through and say, what did you do for the supine roll test, the sideline test, Dix-Hallpike, etc. Okay, here's the recalibration that Dr. Traster talked about. Okay, so this is repositioning with you know, the testing, and then what you did, and then this is the recalibration maneuvers. Here's a retropulsion pullback test, and that is the detailed one, which I believe is the UPDRS. What findings? One step back. Okay, UPDRS grade 1. Okay, so here, and it gives you what it means. Okay, here's dual extinction. Here's the Pittsburgh Sleep Quality Index, and that again says what is the Pittsburgh Sleep Quality Index, where to find it. Okay, with permissions. And then at the end, I like this button, all testing was reviewed with the patient and findings explained. Now, here's your Maddox rod testing, which you can get into if you want. Okay, here's your diagnostic test findings. So under here, what have we got? VNG findings. This took a long time, so I hope you guys appreciate it. You can go in and detailed. It will go through every single test of the VOG, and you'll have findings for every single test. And trust me, putting these findings in was exhausting, as you can see this list. Okay, so there's your detailed, here's just simple and brief. Okay, so that's for VNG. Here's your saccadimetry findings. Okay, and oops, CAPS posturography findings. Okay, and repeat CAPS tests. All in there, man. It's all there. CBS cognitive testing findings. Okay, here's a short version, comprehensive version, testing results. Okay, so you can actually enter the data if you want to, rather than just say C chart and the scans. Okay, here's the tilt table testing. That's included for you. Here's the volitional responses, passive postural responses. Okay, so that's included as well. And finally, you have the Pittsburgh, and it'll say what is the scores of each section. Okay, and I'll have a brief version that I just created. I've got to upload that on there. Okay, so then we go back here. Here's your impression. So I might say occipital neuralgia, and it's not post-concussion syndrome yet. Let's say sports concussion. Good. Okay, and that's that. Now for your assessment. Okay, we're through the hardest part. Here's basically, this just goes along in a line up to about here. So We save this, go into here. What was the diagnosis? This is all on you guys to add. I've got neuro, I've got tons of stuff, so we'll say concussion without loss of consciousness, initial, and there's some dizziness and headache. Okay, there's your, oops, adjustment, okay. Gonna have to take that out of there later. So, now we go in here to assessment, and you hit your diagnosis button. There's that. Now, if you think they have segmental dysfunction, which we already said they did, click that. It says it's noted. Extremity fixations, click that. It's noted. Okay. Soft tissue, it's noted. Just highlights says, hey, okay. There's these diagnoses, but there's also segmental dysfunction. There's extraspinal fixations. There's myofascial soft tissue considerations. Okay. You don't need to put all those in there, but you can just click, 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 click. Otherwise, if you don't want them in, don't put them in if you're just neuro. And hit this. Complicating factors. Normal, or do you have some? Well, let's say you have some. What complicates this? Well, it was, let's say that they catastrophic owing to trauma because it was a crash. There's some deconditioning, not the duration of symptoms. No, there's probably some inflammation. All right, let's go down here. And let's say that there's vestibular deficits, oculomotor deficits, concussion symptomatology. Maybe they have a high BMI, history of CVA or stroke. Maybe they're diabetic. That's up there too. Okay. Maybe there's some canal stenosis. Okay. And possibly some prescription medication issues. Okay. Whatever. They're all in there. And that'll tell you your complicating factors. Go back. After this one, hit this one, red flags. Normal, or do they have some? Well, let's say they got some. Okay, so what do we have here? Let's say there's some personality changes with this. Okay, and they're getting unremitting pain, visual disturbances, vomiting, okay, dizziness, goes on and on and on, okay? And what suggestions? Well, we want further evaluation, additional imagery, and referral to the primary care physician, or to the hospital, or the emergency, or it's all in there, okay? Or you just monitor it. So there's your red flags. Now here's your short-term goals, long-term goals, prognosis. That's it for this. That's all you need. All this other stuff is just candy. You can play around with it. Short-term goals, 50% reduction system, reduction in pain, increased ability to form ADLs, and we'll say improved executive function, improved sleep, and decreased dizziness, and I think headaches is up here. Decreased headaches. Okay, short-term goals. Long-term goals. Let's say functional neurological restoration. That's a general term. Leave that one for the end. Okay. Relief of symptoms. Return to pre-injury status. Let's say elimination of dizziness. Let's say elimination of photophobia. All right. Elimination of headaches. Maximization of function, and functional neurological restoration. Okay, long-term goals. Prognosis down here, unknown but likely favorable, depending on comorbidities. Okay, done. Now we get into plan. This has tons of stuff in it. Okay, the plan. Generally speaking, I always start off with these three. Okay, should probably have them up here, but they're just title things, so they're down here. Informed consent, you don't have to do it. I put it on every single patient, and it just carries through every time. And basically it says they gave you permission to see them. Okay, once you put it in once, it's always there, and I just like to have it on every note. Okay, so informed consent. Here's the purpose of treatment. This is if you're going to be doing musculoskeletal work. Okay, chiropractic manipulative therapy, physical therapy modalities, okay, which different types they are, therapeutic exercises, positional resistance. It's basically everything you can think of at a chiropractic clinic. Okay, if you're going to do that, include it. If you're just doing neuro, don't do it. Don't include it. Okay, take it out. And if you're doing neuro, here's your neuro, and it's just a little summation. Okay, of what the treatments generally speaking consist of. Okay, you don't have to include any of that if you don't want, which is why it's over here, but I like to have all three of those on my patients unless it's at my brain clinic where I don't include that one. Okay, so treatment, all right, well, treatment, here's, if you're manipulating, you put the title, then here's the therapeutic interventions title. Come over here, spinal, it'll ask you what you adjusted, okay, if you want that in there. All right, done. And which technique did you use? Drop table diversified, okay, if that matters to you, done. Extremity fixations. Why did I do that? That's weird. Extremity fixations. Again, all the extremities, let's say we did right distal quad and the right TMJ, okay, then that's in there. All right, that normally doesn't do that. Then therapeutic interventions, okay, so go back here, therapies, back that up a little bit. So here we were in treatment, that's chiro stuff. This, now we're in therapies. Hit therapies, okay, here you got the therapeutic interventions intro. Here's treatment, here's specialty. Specialty is going to be your neuro, okay. So what kind of therapies did you do? Trigger point, flexion, home traction, therapeutic exercise, positional release, EMS, PIR, additional therapies, tons in here, okay, anything you can think of, rock tape, percussion, okay, intersegmental traction. Here's traction because there's tons of different types of traction, okay, we got cervical traction by the provider, flexion distraction, compression, decompression, okay, and these are comprehensive. Mechanical traction, lumbar, cervical, Cox techniques, okay, so that's all in there, all included for you guys, okay. But maybe you don't want any of that, and that's okay. So the specialty now, here's specialty things. So here's my, I like this title here, Therapeutic Neurological Intervention Introduction. This is what we do as neurologists, okay? So here you've got laser, SSAPs, okay, NSI. There's another place for it in case you forgot, or depending if you like it in this section instead. Here's decompression, Brandt-Daroff exercises, canal repositioning, okay, and I'll go through all of them. Canal repositioning / recalibration. Here's multimodal sensory stimulation, which I give for my peripheral neuropathies. Here's vibrational therapy for those. Foam roller, canal repositioning post-treatment, how did they do, okay. Love that one, actually, that title. It's a discussion about that, okay. Fall prevention recommendations. Here's insufflation. Here's the CBS, okay. Then more specialty therapies. Here's the Cox technique, and then you don't really need to worry about that. But when I have a therapy plan, I write it down. The next week or whatever, when I look at it and give it to my therapist to perform, I click that, and it tells them, the italices indicates new treatment therapies, so they know what is new, what isn't. It's easier for them. Okay, so that was under therapies. Okay, so therapies, specialty, therapeutic neurological intervention. Say we did laser, okay, where? And the left hamstring, okay, tells you about the laser. And say we did insufflation bilaterally, okay, that was in there. And then you can get into all your exercises. Exercises you just add yourself, okay, because it could be it's too complicated as to what you do. Okay, now at the end here, so there's your therapies. Treatment plan, that's going to be what you think it is, okay, the treatment plan. Neuro rehab, okay, I don't really use this a lot. If you want, it's there. Okay, here's some cerebellar exercises, cortical exercises. It's real basic. If you're too lazy to, put it in yourself, it's there. Okay, so some basic neuro rehab exercises. Here's general exercises, okay? Here's ones for cervical. Here's thoracic. Here's lumbar. Here's traction. Here's therapeutic exercises in general. Here's home exercises. Here's neuro home exercises, okay? And I love putting that in, so I'm going to have my patients do this 3 times, okay? How many times per day? 3. So here's their home-based neuro rehab program, 3 times per day, okay? Here's aerobic. We want them to include aerobic cardiovascular activity. Here's it specifically, and here's just the title. Okay, so you have cervical, thoracic, lumbar, traction. You have therapeutic exercises in general, home exercises, neuro exercises, everything you could want in there. That's under there. Re-exam I never use, pediatric I never use, Medicare I never use, but these are there for you. Okay. Treatment goals I never use, recommendations, because they're going to be in there. Okay. Then this is the powerful button down here. Okay. And this one. So really going to use boom, 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 these three. Maybe that, this one, and that one. So, handouts. What did we give them? Recommended diet, anti-inflammatory diet. Okay. Diet was what? Let's say ketogenic. Okay. That tells them recommended diet ketogenic. Or the anti-inflammatory is a big write-up about that one. Okay. That's under handouts. Now, go back down here, patient response, and close. Tons in this. So here we have patient response to examination or treatment. Big, powerful button. Okay, I put that in at the end. Now here you've got quick links to further tests and referrals, further imaging testing, activity resumption, autoimmune inflammation, the therapeutic intervention paradigm, maybe counseling, mental health, the fibromyalgia questionnaire by the ACR. If they have fibromyalgia, you should give them the questionnaire. It's free online. Okay, and if so, it'll ask you to fill it. Here's the form for that. Here's home-based multimodal therapy. Here's a surgical referral. Okay, here's a regression prevention. If you take insurance and the patient is not getting better or will never get better but will worsen without your care, this is directly from the insurance companies. You click this button. There's two different versions here, and it'll say the patient is on a regression prevention and they need your care. Okay, and that will get them coverage. Okay, here's a care plan and declination of treatment, testing reviewed with the patient, which is also in another area we talked about. These two buttons, neurology write-ups and more. Okay, don't forget this one we'll come back to. Neurology write-ups. These are huge. I've written them up for you. Here's a write-up on concussion, and part 1 and part 2. Here's part 2 with opinions in it. Okay, here's a write-up on POTS. Here's a write-up on pica. Okay, pica testing negative. Here's a write-up on dysautonomia. Here's a write-up on patient needing detailed counseling. Okay, and here's a write-up on symptom magnification or perseveration. Okay, so there's a few other write-ups, and the more write-ups that I start doing, I'll include in here. Okay, so that's done for you. And basically, to show you, here's the concussion write-up. It says basically the consensus statement on concussion in sport, as you know, Dr. Carrick outlined for us at the Berlin conference, states that this is what the patient should have and what a concussion is. And then you hit part 2, and it'll talk about your actual patient. It says right here, okay, Mr. North, here's that weird thing again I was telling you about. Okay, so we got to change that. It only does it at a few different places, but Mr. North demonstrates significant symptomatology commonly associated with TBI and post-concussive events. Injuries of this kind have been well documented, and it goes into all the clinical stuff that we tell them. You don't need the clinical stuff, so you don't. That's why it's its own separate button if you don't want to include that. Okay, at least this one quantifies that it is a concussion based on what? Based on the Berlin conference and the world's experts. Okay, so then we go back. Now, that's neurology write-ups. Now you hit more. Oh boy, we have tons of stuff here. Here's a discussion title, recommendations title, therapeutic neurological intervention intro. We already had that. Here's a old version of neurological treatment. Here's decompression table, miscellaneous title, clinical update title. Okay, functional medicine if you use that. There's a just write-up about it. Sleep recommendations. Okay, neurological and clinical depression title again here if you didn't do it in the other section. Okay. And again, home-based therapeutic intervention, fall prevention recommendations. Okay. Inversion therapy, aerobic cardiovascular activity. Here's nutritional and supplementation advice. So just a few of them: B12, D, glucosamine. Okay. Here's diagnostics and testing and here's specific recommendations. So diagnostics and testing. What diagnostic testing is to be performed immediately? Which ones and when? And then which ones to repeat. So let's say which ones to be performed because my staff didn't do them. The VNG. That basically means get it done. Now, what ones do we want? Let's say we want VNG, CAP, saccadimetry, CBS, and SVV, as well as the Pittsburgh. And in when? In 2 weeks. Okay, there's the repeat to be done. Your staff can hopefully read that. Okay, so there's your diagnostics just for testing. Here's recommendations, lots here. Here's just the title if you want. Here's just providers if you want. Here's tests if you want. Here's just equipment if you want. Okay, here's general recommendations if you want. Okay, so and then here's full, all of them together, and it'll ask you each one of these. Okay, so for instance, what further provider recommendations? Let's say a licensed massage therapist and a mental health specialist. They're a little bit off. Okay, what further testing? None at this time. Okay, what items or services recommended? Cervical traction unit maybe and a cervical pillow. Okay, good. What type of diet recommendation? Ketogenic diet and an anti-inflammatory, well, just ketogenic diet. Okay, and so you see there's the total recommendations button, which is that one that says full. Okay, then you can say recommendation to the primary care physician for possible medications, recommendations for time off, recommendations for a disc issue. Here's the anti-inflammatory diet. Here's fasting with time values. Okay, so then there's even more patient response. Okay, here's the write-ups I was telling you about. Okay, here's a radiologist report you can include, testing reports, emergency department urgent care note. Okay, that's all in there. And then some of this is specific to Maryland. And then even more. So maybe you want them to go to detailed counseling. Okay, here's more of the write-offs: time off of employment or schooling, referral to a colleague, meals before sleep, sleep recommendations. Here we didn't do an examination because it was a discussion. Return to employment. Okay, return to school. So you see this little button here, patient response, is powerful because then you got these power buttons in here. More, and more. Okay, so coming back to it all, at the end, let's say patient response to care, and you got these things here: patient response to treatment short, which just summarizes it, and then the examination short. So here, they did great with the exam, done. Okay, I like this button which says patient response to treatment. They tolerated treatment well. Okay, they had slight improvement. And what did they have? Increased range of motion, decreased pain, decreased headaches, improved balance. Okay, done. Then you go way back to the middle, and at the end, here's your treatment plan. Okay, lots of stuff here. Basically, you're going to use this one, frequency of care. You're going to use reduction of care because of gains, and patient discharge for MMI or PRN. But frequency of care, so what? We're going to see them daily, let's say for 1 week, and reevaluate for further treatment. Okay, and that's it, done. So now you can see your total note to review. It has everything listed. This is the symptoms. Okay, patient provided this history. Here's the history that you took. Here's all of the background information from the data that they intake forms. Here's your objective testing that we had for description, vitals, complete physical. Here we went into the neuromusculoskeletal here in case you want it. And you see everything quantified there. Then we went into the detailed neurological exam, and that's got every single section that we talked about. Overall, you've got gait, cranial nerves, frontal cortex, cerebellum, oculomotor, vestibular, and then further diagnostic testing. Or testing. Okay, that's all in there. Vestibular, fundoscopic, 1080, NSI, subjective visual vertical, CAP, saccadimetry, VOG, CBS, Pittsburgh, tilt table, pullback, tests, everything, and then the impression. Then your assessment, okay, diagnosis, complicating factors, red flags, short-term goals, long-term goals, prognosis. Plan, okay, what is the plan? Informed consent, here's the plan for the treatment. Here's any manipulations we did, adjustments or extremities. There's also ribs that's in there, okay. Here's the therapeutic neurological intervention we did, laser, insufflation, then you can type in all the other stuff. Here's your home-based neuro rehab program. Patient's supposed to do it 3 times a day. Recommended diet. Okay, discussion of the concussion. Diagnostics to be performed. Repeat diagnostics in 2 weeks. Recommendations, this should probably be at the top with the other recommendations. So just cut that out. Okay, recommended diet. We didn't really need that in there because we said it already. So there's your recommendations. There's your discussion of the patient has a concussion. Diagnostic testing to be performed. Repeat diagnostics in 2 weeks. How did the patient do with the treatment? And the treatment plan. And we're finished. Okay. And over here you put your charges. So hopefully you guys appreciate the macro, and it helps you to do a better job, I think, clinically. It's again, the whole point of this was that I can't type, and so the point was to be able to have something that is effortless, and again, the more you use it, the more friendly it becomes to you, and the ease of use dramatically increases. Okay, you can do almost everything without typing a word. Okay, the options are there for you. It seems very detailed right now, I know, and overwhelming, and that's just because there's so many options included with it. But once you get to know those few hot buttons, then it'll guide you through everything that you need. Okay, I'm going to offer training sessions on this. I've, in my opinion, I've made that very affordable based on, I think most of you would agree, based on how much you probably collect per hour in doing what we do. The price point, I think, is very fair. If you're interested in that, I'd be happy to, sit down with you. I want people to get the most out of this because it's just good for us. It's good for our profession. It's going to make your life easier. It's going to give you more family time, more time with your patients. It's going to give you a polished product that attorneys love to work with, that fellow healthcare providers, especially medical doctors, love to see, that our colleagues will love to see, noting and seeing what you tested, what was positive, what wasn't, and being able to quantify that. And just having a report like this that you can share with other healthcare providers, it is unbelievable how much this has changed my practice. I have medical groups and law firms contacting me repeatedly that I've never even met, just because they heard from colleagues because of the detail of the notes and also the treatment. So there it is. Hopefully you're happy with it. I apologize for the length of this. And again, when you get fast at this, the musculoskeletal you can do in about 15 minutes. The just neuro is also about 15 minutes. If you combine the two of them, it's 15 or about 20. Okay, on a typical note. So thank you so much, and I look forward to hearing from you guys in the future. Take care. Oh, by the way, my contact information, you could email me at drdanlane@hotmail.com. That's DRDANLANE @hotmail.com. Forgive the designation of hotmail.com, but it's my main one. I check that one frequently. Reach me from there. Put something big into the title of it so that I recognize it in case it goes to spam.